Good morning, everyone. My name is Jenna, and I guess just want to double check on the sound. You can still hear me okay?
Yes, you sound great.
Okay, perfect. My name is Jenna Burke, and I am a quality improvement specialist with Health Services Advisory Group, and I have been working with the Patient Family Advisory Council since it started in 2017, and within the last year started leading the work. So I'm very excited and honored to be able to be here today to share more about the work HSAG has accomplished with our PFAC. And I'll hand it over to Randall so he can introduce himself.
Good morning, all. I'm happy to be here to share my experience. Just briefly, this all started as my wife and I were taking a diabetes empowerment class at Pasadena Senior Center, where I met Alexa Hughes, who was facilitating the class. And it was so interesting to me as far as the interactive component of learning. And since then, I've met many staff members from HSG, and I'd just like to call out a few of their names if I might. And I went to DEEP, which is the acronym for Diabetes Empowerment Training Program. And I met Bertha Sandoval, as well as Julianne Moss, who I started out with this program in 2017, as well as Jolynn Hanger and Amy Osborne and Lauren Hensley and Don Williams, and now Jana Burke. I'm working with her. So I'm happy to be here and share some of my experiences with you.
Perfect. All right, so our objectives for our presentation today is to be able to describe the various ways that you can integrate patient family advisors into quality improvement work, really recognize the importance of integrating patients and developing quality tools and processes, and then being able to share these great tools that have been developed by patients for patients. So I wanted to start today's meeting off with a meeting reflection. This is something that I do at the beginning of all of our Patient Family Advisory Council meetings. Really just start the meeting off on a positive note and acknowledge all of our family advisors for still showing up and being dedicated to drive improvement despite all these crazy things that's going on in our world today. So I'm going to go ahead and just read this quote for you. This is a quote by Charles Swindoll, and the quote is, "The longer I live, the more I realize the impact of attitude on life. Attitude to me is more important than the facts. It is more important than the past, than education, than money, than circumstances, than failures, than successes, than what other people think, say, or do. It is more important than the appearance, giftedness, or skill. It will make or break a company. The remarkable thing is that we have a choice every day regarding our attitude, and we embrace for that day. We cannot change our past. We cannot change the fact that people will act in a certain way. We cannot change the inevitable. The only thing we can do is play the one string we have, and that is our attitude. I am convinced that life is 10% what happens to me and 90% how I react to it. And so it is with you. We are in charge of our attitudes." So thank you all too just for being here and taking the time to learn more about the Patient Family Advisory Councils and the great work that they can do, because we need this now more than ever. So just to give you a little bit of background about who Health Services Advisory Group is, we are part of the Quality Innovation Network and are the quality improvement organization for both Arizona and California. There's a quality improvement organization in every state throughout the country and in every territory, and it's actually the largest federal program that's dedicated to improving health quality at a community level. So it really puts HSAG in a unique situation where we're able to engage our Patient Family Advisory Council in multiple healthcare settings, multiple topics, and work with multiple different kinds of providers. So every 5 years, CMS prepares initiatives that they want the QIOs to focus on, or for my acronym, Quality Improvement Organization, or QIOs. And for the next 5 years, they have identified the following topics: working on improving coordination of care, working on reducing avoidable 30-day readmissions, reducing adverse drug events, improving opioid safety and reducing opioid-related overdose deaths, working on improving infection prevention and reducing infections such as C. diff, working with nursing homes and improving their quality measures, and then working with chronic disease management with a particular focus on diabetes, pre-diabetics, and individuals with chronic kidney disease. But regardless of the topic or the metric we're trying to meet, the patient is the center of the care, and patient is the center of care and of everything we really do. So we wanted to take some time to hear from you, and if you guys don't mind typing your responses in the chat box and let me know what you think. What is the most underutilized resource in the healthcare environment for improvement? And just take a second for you to put those responses into the chat box. And then Kim, do we have a couple responses coming through? Do you want to go off?
We sure do. They're coming in fast and furious. And let me tell you, it's patients and families, patient experience, patient and family voices.
Exactly.
Yeah, too. Yes. So.
So we have a smart audience right on the dot. I mean, patients are the most underutilized resource for improvement. And there's so many of them out there that really want to help and make a difference. So again, wanting to ask you and being able to put in the chat box, what does patient engagement mean to you? Patient engagement, depending on who you're talking to, can look different in a lot of ways. It could be a primary care physician and you're working with a patient to develop shared goals, shared decision making. It could be having a patient go through a training program and having them pilot that program and providing feedback. It could be having them look through your educational materials. Just want to hear from the audience on some ways that you've been able to incorporate patient engagement in the work that you do.
So I'll start to read some of these responses. Integrating patients into their healthcare, family involvement, more than just filling out a survey, listening to patient voices, asking patients what matters to them when it comes to their healthcare. Authentic two-way communication, active listening, asking them for their goals and what matters most. This is a very smart audience.
Great responses. Anything else before we move forward?
Creating decision-making tools such as Ostomy and G-Tube, making changes based on patient feedback, both verbal and written.
Yeah, and really the list can go on and on because ultimately, as I mentioned earlier on that last slide, patients are at the center of care and we really shouldn't be making, there's not many decisions that should be made without hearing their voice. So I like this nothing about me without me and integrating the patient in every way we can, even if it's not the more traditional way. All right, so I wanted to start with a little bit of history of HSAG's Patient Family Advisory Council. So as I mentioned earlier, it was established in 2017, and we're actually very fortunate that we have representation from all 4 states that we have contracts with. So that's Arizona, California, Florida, and Ohio. And the PFAC meets monthly through WebEx. So I know all of us are adjusting. This is my first virtual conference that I've ever presented at. But for HSAG's Patient Family Advisory Council, virtual meetings is not anything new to us. That's how we've been meeting on a monthly basis, and it has been very successful in being able to collaborate through that method. So our overall goal is really being able to use this council to integrate the patient's perspective into our services, our resources, and our materials. So I will go ahead and pass it over to Randall so he can speak a little bit more. You know, he touched on it briefly in his introduction on how he became a part of HSAG's Patient Family Advisory Council.
Well, upon becoming a part of the advisory council, what I really like is what I call the big threes, how we identify ourselves first of who we are, what our objectives are and what our responsibilities are as patient advisory on the patient advisory council. And I like the statement that we have, recognizing that improvement is a journey, not is not a destination, because everybody's is just different. And I really like the fact that we have an opportunity to share with patients and to get to listen to them and to hear what they have to say, as well as speaking with their families and having the opportunity to have patients empower themselves in their own participation of their own care. I think it's really helpful. So that's what I've found very helpful. Each time we sit down, we always identify those 3 key areas, and then we work with the purpose, challenge, and our goals. And it's been quite interesting for me to sit down and just to listen and hear the different perspectives from a patient's perspective, and sharing, being able to share that and really be heard and take that and carry it away and actually do something about it. That's why I continue on with it. It's so good in that way.
All right, so throughout this presentation, we're going to be highlighting 4 of the projects that we worked with the Patient Family Advisory Council on, but just wanted to provide you a list of some of the other work they've done. I wish we had more time and we'd be able to share more with you, but they've done work around developing posters for depression screening, which we'll talk about in just a little bit. They've developed handouts focused on opioids for pain management, have provided evaluation on chronic disease patient zone tools where healthcare providers can use these to educate patients on the actions they could take based off of the symptoms that they're feeling. They've developed education on the difference between sepsis and sepsis shock, also education around antibiotic stewardship, developing a pre-admission checklist and bedside huddles and how you can make patients more comfortable with being a part of those huddles, education on preventing falls, and then they helped us with developing home health videos and palliative care videos, which we're going to be talking about with you in a little bit later in this presentation. So we thought it'd be great to start out with the first project that the Patient Family Advisory Council worked on, and that was the alcohol depression screening posters. So there's a lot of important topics out there. So how do we get focused on this? So what we found is that there's a high prevalence of people who have alcohol use disorder or depression. However, they're not getting the treatments that they can benefit from because these 2 conditions are extremely underdiagnosed. And so, and also people with those conditions are at a higher risk for being admitted to the hospital and having a readmission. So CMS had set us out with the goal of improving behavioral health outcomes with a primary focus on the primary care setting. So the purpose of this was to increase the number of individuals who are getting the depression screening when they visit their primary care physician. And the challenge was really patients don't understand what the screening is, why they're asking that information. It can make them feel uncomfortable. So sometimes they refuse to complete it. And so we took this to our PFAC to be able to gain the patient's perspective on how to improve those outcomes. So this is what the final poster ended up looking like. It was the screening for the best possible you. And now I'm going to hand it over to Randall so he can talk a little bit more about his experience developing this poster.
Yes, this was quite interesting. And as Jana said, this is the final project. But if you notice in the under the happy people on top there, where it says screening for the best possible you, that started out as just the lettering was just white lettering. And so we made some subtle changes there and emboldening those letters and making them so they'll stand out more in making those posters, and also some of the wording as to why and how we would use it. We actually made changes there, and they took them away as we discussed them and came back with new results. And this was the final copy that we had.
And then something that I love about this group is that not They're always willing to help us with the development of resources, and they provide us with great feedback, but they also are willing to help us with implementing these tools and being able to disseminate them throughout the community. So the Patient Family Advisory Councils had actually gone and taken these posters out to their own primary care physician, and we ended up distributing over 400 posters throughout the 4 states. So a great reach, and again, just want to hand it over to Randall to speak on his experience in sharing this poster in his community.
In this project, what we tried to do as well, is that's why we have the Happy Stick people, to make the posters as simple as possible. So rather in the waiting room, the patients who are, it's attractive enough for them to take a look at it, or someone who might be with them, as well as what was really powerful is it wasn't just for the patient's waiting room, but also we had information for the staff and how they would approach the patient and how they would share that information with them to do their best not to offend them. And so we did distribute those to our local physicians. We took them to our local doctors where we actually are treated and seen, and asked would they be willing to do that. And from there, I think it just spun out into other groups. So as well as even as far as I'm concerned, our local senior citizens group, we actually did that as well. So it worked out well in that fact.
Yeah, and I like so Randall said they help simplify things, and that's something where Randall saves me at all the time, because I am a data and research nerd. So when I'm developing a product, I just want to get all the information so I can share as much information as possible with the patients. And then Randall and the rest of the PFAC group is able to say, whoa, 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 Jenna, this is way too much. Let's stick to the facts, keep it easy to understand and read. So it really is a great partnership in being able to leverage all of our strengths to create these strong documents. All right, a second project that we were working on was increasing education around opioid prescriptions for pain management. So we know that there's a high prevalence of opioid prescriptions among older adults, and in fact, there is more than 1 in 4, or 29% of older adults stated that they had filled an opioid prescription within the last 2 years. We also know from older adults that when they're being prescribed these prescriptions, whether it's from a physician, a nurse practitioner, or when they're seeing the pharmacist, there's a lack of education that's being provided around the use of opioids, the symptoms that might occur, and the risks that are associated with taking opioids. So the purpose was to empower patients to ask questions about how to use pain medications, when to use them, and how to properly dispose of them. And the challenges were really that patients don't know what questions to ask. We're still learning a lot about opioids and the side effects that they can have, and they're also not aware of the high risks that can be associated with using opioids. So our goal was bringing this work to the patient family group to understand their perspective on the use and the risks around opioids for pain management. And this is a final look of the product. It was when to ask your doctor before developing a checklist for before taking opioids. And then I'll hand it over to Randall to have him share about this work.
Again, this was, we were provided a set of guided questions, and we discussed those questions and looked at this checklist. And again, we made a few subtle changes to the wording, as well as we came up with short-term and long-term goals for individuals with that are using opioid for pain management. And what was good was we came up with a list of maybe they may be exercising, a diet, reduce your stress, maybe take a yoga class, weight management, and if you're smoking, really take a look at stop smoking. Lifestyle changes is what we really looked at real carefully. And I even noted that last week, I noticed on Good Morning America, they had a segment on a young man who had been prescribed opioids and was taking them for a long period of time and just became addicted to them. And now they're doing this research where they're doing a deep brain stimulation, such as they've used this technique with people who have who have actually brain disorders, and it's helped them. And now they're inserting this into their brain as well as helping them to be able to hopefully cure this addiction of opioids. So it's really fantastic in that. But in this subject that we were talking about, this checklist, it was really helpful to be able to provide information for that. And I thought it was really great. Again, once again, we were listened to, and they took some of our advice here.
All right, so the next project I want to share with you was the work that we did around increasing education on palliative care. So before we move forward, I just want to hear again from you in the audience, in the chat box, if you don't mind typing your responses. What do you know about palliative care? We find that there's a lack of knowledge here around not only patients, but with providers as well on what is palliative care, who can benefit from it, who provides palliative care, how is it different from hospice? So a lot of questions that a lot of people just don't know the answers to and could really benefit from these services. And we'll just give a couple seconds for some responses in the chat box.
So far we have symptom management for chronic or acute disease. Another great comment, all care should be provided with palliative care guidelines, pain relief and comfort. I've heard a wide range of experience that some think it's giving up.
Yeah, so there's a lot of confusion about what it is and why patients are taking advantage of this great service to be able to help them manage their symptoms. And so we had so the purpose of this was empowering eligible patients to participate and benefit from palliative care services. And the challenge was really just patients do not understand what hospice or palliative care is and what the difference is between hospice and palliative care. So we went to the PFAC to be able to address the patient's concerns and perspective, and we were able to develop these 3 videos. So the first video is just focused on what palliative care is and how palliative care can improve your quality of life. Then we have a second video focused on where and how palliative care is administered. And then the third one is the role of palliative care in your life. So these are all on HSHE's YouTube channel. We encourage you to share them and being able to help others educate patients on what palliative care is. And I'm actually going to take a second just to be able to share these videos, just a quick snippet of one of these videos with you so you can see what the final product looks like.
And Jenna, you might need to, there you go.
What is palliative care?
You know, Randall, some of my colleagues in medicine ask me the very same thing. The word palliative means to comfort. So if we comfort a symptom like pain or shortness of breath or nausea, we palliate that symptom. Now, the new meaning that really is merging into healthcare now is the goals of care discussion. What would the goals of a patient facing serious illness be? What would their goals be? Not the treatment goal of the physician, but the life goal of the patient. Do they want to come back and forth to the hospital? Do they want to have their blood drawn? Or would they rather be at home? So comforting symptoms and advocating for the goals for that person. The comforting part of palliative is to support the patient's goals of care, the kind of care they want for the rest of their life. So palliative care is symptom assessment and comforting, palliation, and goals of care of the patient and supporting that.
How does palliative care differ from hospice?
The word hospice
Okay, can you still hear me?
Yes, we can.
All right, so you can see it was a great collaboration with Dr. Hawk, who just does an amazing job at being able to explain this. And I'm going to let Randall speak a little bit more about his experience with this project.
Yeah, I really enjoyed this segment, this project that we worked on with Dr. Hawk. One, he communicates so clearly, and he also acknowledges that a lot of his colleagues don't really fully understand what palliative care is. And I think someone actually said in the chat box that it's this system assessment management that we do. And also someone asked, does it mean give up? Well, I like the way he phrased it. He said that it's instead of the end of life care, it's the rest of life care. And that puts a positive spin on it for me to give you a hope, as you read earlier about attitude. Our attitude is everything when it comes to especially our health. And so it empowers the patient to ask questions and to live live this life the way that they see fit. Because who knows your own body better than yourself, how you're feeling. If you've been having blood drawn from you too frequently and having to move back and forth, and maybe you just want to sit still, maybe go outside, have the fresh air, and you can do that with palliative care. So you have a say in your lifestyle with as he explained it. And so it was really insightful for me because I relate this situation even to my own mother who passed away last year, who was under hospice care. But by me understanding somewhat about palliative care, I was able to ask the right questions and try to get certain aspects of that taken care of, what we as a family felt more comfortable about. So I really enjoyed this project.
Thank you. All right, so the last project that we want to share with you is focused on increasing education around home health. So again, why did we focus on this? Well, what we found is that a lot of individuals who are getting referred to home health are either denying the services or not letting them come into the door. And the reasoning for that has been shown just there's a lack of education. They may feel that there's an invasion of privacy, and they're just really not aware of what these services are and who's coming into their home. So how can we? So the purpose was to empower patients to be able to participate and benefit from home health services. And the challenges is really, I mean, still receiving care at home is now becoming more and more common as we start to move into a more virtual world. But it's a new concept for older adults to receive care at home, and they're not comfortable with it because they don't know what those services are. So we went to the PFAC to be able to see how we could better educate older adults on what home health is so that they can benefit from those services. So this is the home health services video. We're not going to play this video just to save time. But again, I put that link on there. As Kim mentioned, you guys are going to have copies of the slides so that you're able to take this and be able to share it with others. And just speaking again about the reach of these videos. So this video is actually, it ended up getting so much attraction that a big company with their Silverview, they asked permission from HSAG if they could upload this into their system so that hospitals across the country that they work with would be able to utilize this video to be able to educate their patients on what home health is. So then I'll hand it over to Randall so he can talk a little bit about his experience with this video.
Okay, this project was really interesting too. Again, we were brought some information with guided questions, and also charts with colors, red, green, and yellow, in which everyone's usually is pretty familiar if what red, green, and yellow. Red meaning there's a warning, green it's safe, and yellow would be caution. And we had a chance to choose between flags And we have an interesting group. I like our group with flags where people thought it was more like racing cars or someone flagging you down. But we chose to go with the lights because most people drive or at least have ridden in a car. So they understand what red, green, and yellow are as far as the light signals go. So we developed a chart for them to be able to ask certain questions, the who, what, and why questions. And I thought it was very helpful. And our group came up with a lot of great questions and real good conversation on that.
Yeah, and I also want to say it's just great to get the feedback they provide is little things that I would have never thought about. So for example, in this video, we had referred to patients as Medicare beneficiaries, and they said we don't relate to ourselves as beneficiaries. We would never call ourselves a Medicare beneficiary. And when you think about it, that makes complete sense, that it's just in our world such a common term that we didn't even think twice about including that in the video. So it's the more perspective we can get from them, the better the product ends up turning out. All right, so those are some of the previous projects that we worked on, and now we want to transition a little bit to what our current work has been focused on. So we had just finished up working on developing a heart failure 7-day linear discharge plan. So both in Arizona and in California, and really amongst many states across the country, heart failure is the top condition has the highest rate of 30-day readmissions. And often those readmissions occur within 7 days of them being discharged. And they're receiving a lot of information at the hospital. It can be very overwhelming. And so we wanted to complement the education that was being provided to them at the hospital by providing them with this checklist so that it would be easy to follow. They can get a reminder of all the things that they need to accomplish within the first 7 days of being at home. So this was our first condition that we are working on, and the plan is to someday expand this to other conditions as well. And then I'll hand it over to Randall.
Okay, this again was a nice checklist again before leaving the hospital. A lot of time, and we discussed, I think quite a bit in depth about you're leaving the hospital and you really don't know, you don't have a plan. And so we discussed this, and as far as putting a plan together and a checkoff list of what you might need, what you need to ask, have your doctor's information or several, or your doctors, because you may have more than one. And so we had a good checklist of what you would need to do once you actually before leaving, and what you need to do once you get home. And so we made a list of questions, and I thought this was another good chart for daily tasks of what you would need to do, and not only for the patient, but the caregiver. The caregiver or family members would need to know this information as well.
And I believe this one, when I first showed this to the group, they were like, whoa, this looks like an encyclopedia. They helped me chop down the language a lot. All right, and then our most recent project that we're working on is working on developing education to help empower patients to perform hand hygiene in the nursing home setting, as well as help keep their staff members accountable for washing their hands when providing care. So as I'm sure most of you know, washing your hands is one of the most effective ways to prevent the spread of COVID-19. And really, I mean, as the patient is probably the most important person in their healthcare team, and being able to work with the nursing home staff members as a team to make sure that they're washing their hands and the patient's washing their hands as well. So we are currently working on that and don't have a final product yet to share, but Randall, you want to speak a little bit about this new project?
Yes, we're actually working towards developing, again, maybe another nice poster that would simplify the washing of your hands. And we also had a question, just to give you a little insight as to one of the questions we had were, is it better hot water versus cold water as far as washing your hands? And the medical literature for Food and Drug Administration said that hot water that's comfortable enough to wash your hand is really no different as far as killing the bacterias on your hand as cold water, but it would be better to go ahead and use hot water because it because it frees you from the oils in your hands. Because of us having to wash our hands so frequently now and use hand sanitizers, I'm sure a lot of people are lotioning their hands. So that's one area that we're looking at and trying to get a good information and simplify that for patients and staff members to just wash their hands, as well as how do we answer the question of patients who are kind of immobile? How do we get their hands washed with the staff? How would the staff handle that? And how would the information come across to make that not threatening if the patient is saying, did you wash your hands, or can you help me wash your hands? Questions like that are coming forth right now. So this is another one of those we have to be careful projects as far as the wording and speaking to one another with respect.
Absolutely. All right, so that really brings our presentation to a close, just highlighting those 4 topics and really highlighting how these are challenging topics. You know, palliative care is confusing, not being comfortable with receiving care at home with home health, being able to talk about opioids and depression screening, and really improving challenging topics by engaging our Patient Family Advisory Council in everything that we do. And really, by doing this, there's so many outcomes, and just by your responses in the chat box, I know you guys you're already aware of all these, and just being able to improve quality and safety, being able to improve financial performance, patient outcomes, employee satisfaction and retention. You're enhancing your market share and competitiveness, and you're able to improve your evaluation scores. So there really is no downside to integrating patients into all the work that we do. So our last question to you, if you don't mind putting your responses in the chat box, is how can you engage patient advisors? So we've provided the first project was focused on primary care physicians. Then we talked about the palliative care setting, the home health setting. We talked about opioids, which touches all settings as well. But if you had a magic wand, what is the one process or item that you would want to improve through patient engagement? I'll just give you a couple of seconds to answer, put in your responses.
While folks are thinking, I think there's such an endless amount of processes that we could really use patient engagement to help to improve. But gosh, so there's a few responses coming in. Helping all employees see waiting and anxiety from care through patients' eyes. Yes. Palliative care would become available to all patients. Currently, the few providers are overwhelmed. Yes. Nutrition awareness for oncology patients. It's not one size fits all. Education on advanced care planning, importance of having an advanced directive, reading patients' body language as well as verbal. Yes, so important. Signage throughout the hospital and clinics from the patient's eyes, what works and what doesn't. Patients express inconsistent care with home health. Families want to partner in their child's care. A couple more, ease of access, care in the continuum, identifying person-centered goals and helping to achieve them, shared decision-making, the value of digital medical record keeping from a nursing home perspective, education to families, allow the doctor time to listen to patients talk about health-related issues and not give body language that they're in a hurry or uninterested. Oh my goodness, there are a million coming through. As I said, there's no shortage of processes that we really, really need to be working together with our patients to engage and work together to improve. I like this.
I couldn't agree more. That the opportunities are endless. So I really I thank you all for taking the time to hear about some of the work that we've been able to accomplish with our Patient Family Advisory Council. And I encourage you to be innovative and think about how you can engage your patients and improve the work that you're doing in the various ways that you just shared. So if there's any questions, Randall and I are happy to answer them for you.
Yes.
I don't know
Okay,
if any questions have come through the chat box or not.
There are. I'm going back to the beginning here too, and there's, I should have pulled them separately here, but let me, here we go. First, this is a great question. How were the goals and responsibilities determined for the PFAC?
So that I'm happy you asked that question, and I apologize. I should have mentioned this earlier. When we were on, or the PFAC, it does have representation from all of the different states, but we also have a lot of staff members who are on the Patient Family Advisory Council who are involved in various projects. We have several different contracts within the company and have representation from almost every contract so that we can meet and talk about where are we having our biggest challenges and where could we be able to integrate our PFAC and their opinions, and then kind of make a running list and try to do the ones that have to be finished first. So, I mean, as you guys mentioned, there's so much that we can involve them in. So we have a very long running list that the PFAC will never get bored. So it's something where it's not hard to pick a project, and based off of deadlines and just where the priority might be with different contracts, we select those certain ones first.
Perfect. There's also a question, what was the data about achieving the goal of the alcohol and depression poster? So I think maybe what was the data you were seeing before that resulted in this goal of making the poster?
So the data that the goal was to be able to see the volume of beneficiaries visiting their primary care physician, to have an increase in numbers of physicians who were documenting that they were conducted that screening. I know that we distributed the posters to over 400 providers, but what that actual number ended up looking like, I don't know off the top of my head, but I would be happy. I don't know, Kim, if you can share information with me, or I can follow up to be able to share those numbers, because we definitely have that. I just don't know it off the top of my head. I apologize.
No problem. And here's a question. I think this is actually for everyone too, but it's a great question for us to all be thinking about. How much are families and caregivers included in training like this for palliative and hospice care? From Sharon. So, you know, obviously you have absolutely included families and caregivers that are part of the PFAC too, but I'm wondering from everyone else on the line too, that's a great question to ask. How are you including families and caregivers? And that you can certainly type that into the chat. Also a great comment here too, impressive what you've accomplished. I smiled as soon as I saw that the start of this comment, because I thought, oh yeah, certainly with all of these accomplishments, this PFAC must have been together for a decade working on all of these, right? But no, a lot has happened. So, and this person, Jan, is on a PFAC for another QuinnQIO. Has really enjoyed the opportunity to feel like we're making valuable suggestions that are sought out and appreciated. And boy, isn't that really the goal? That, you know, the shared goal of us on a PFAC is that we really the input is valuable and sought out and appreciated. So absolutely.
And I'll say one, oh, go ahead.
No, go ahead.
I was just going to say, as you know, the example Randall provided, I think that the work around palliative care was where we heard the most stories from the PFAC, where they have a friend or a family member who, you know, was in a lot of pain and could have benefited from this service. And because of the work that they accomplished with HSAG, they were able to help out their friends and their family members. So there's the dissemination of the tools on our end with the hospitals and facilities that we're working with, as well as them taking that knowledge to their family and friends. So it's really cool to be able to see that grow.
Yeah, it definitely
Also,
gives you
one very
another,
important question. Oh, go ahead, Randall. Sorry.
no, I was just going to say it just gives you another tool in your box to feel more empowered to ask questions that are needed as you begin to, because no one no one plans on being sick and so forth, but as you encounter these, you're able to step up and ask questions that you normally probably would not ask or think of. So it really does help your family. If, and especially I would encourage you to have someone get involved in being patient family advisory, because it heightens your awareness of even just walking into a doctor's office or hospital.
Absolutely. And I think that also is another, you bring up another great point too, Randall, how important it is for those of us in healthcare that are participating in a PFAC and encouraging patients and family members to join us, that we really make it, we set the expectation that if we are using language that is, or lingo that is just, for healthcare workers, that we make sure that we stop, we change our lingo, that we have the members of our PFAC be very comfortable in stopping and say, wait, I don't understand. What does that mean? What is this? Wait, what is that? Because that's another key piece of this, is empowering patients and families to be able to really, truly partner with us. And if we aren't helping, to understand the language that we use, then that makes it even harder too.
Yes.
Before I forget, there's a question, a really important question from the very beginning. Jenna, there was the quote that you started the session with here too. Who is the author of that quote? We have a question about that, so they could look that up again.
Great question. So the author was Charles Swindoll. And I picked that quote because I had shared that at one of the previous PFAC meetings. And then Randall, I don't know if you want to share how you were able to share that with others, and so it inspired me to say it again, but Charles and then Swindoll, Swindoll.
Yes, it's a very powerful. I'm glad you all should look that up. For Attitude, I was on a couple of other calls and just used that as Jenna shared it. I was on a family Zoom call and also another call, life group. We have different life groups with our church, and we were on a call with that, and I shared the Attitude, and it covers everything. And I just think, especially when we're talking about patients and doctors, if we can begin to have the attitude that we're all in it together as a team. If we look at a team and we're all wearing the same jersey, the doctors, the nurses, the patient, and the family members, so we're working together as a team together to gain insight and try to help the person recover, or at least live a comfortable life, live a comfortable rest of the life. Yeah.
Wonderful. There's a question here too. How do you recruit your PFAC members, and how many members do you have? And this ties into another question asking which hospital is this? And wanted to remind, this is actually not just one hospital that's represented for this PFAC. This is a multi-organization PFAC that's led by HSAG, which is one of the quality improvement organizations. And so they have far reach here too. So would wonder then, how do you recruit PFAC members in this type of PFAC?
So great questions. So we have multiple contracts, as I mentioned earlier. So it's not multi-organizations, it's one organization with multiple contracts. And then as Randall kind of alluded to earlier, he had been a part of the diabetes work. And so from our work with the contract, when we were interacting with beneficiaries and having them participate in workshops and so forth, we were able to recruit through that type of work. And then we also were able to recruit through family members, staff members who had family members who were older. So really, we were very open to having anyone who was interested in participating be a part of it. So we're in California and Arizona, so we're able to use our PFAC to help the hospitals, physicians, nursing homes, home health agencies within those two states. We also help the facilities develop their own PFAC and helping hospitals facilitate those and being able to accomplish new work with their PFAC members. And then, did I address all? I think that was it. I apologize.
No, that's wonderful. Also, we have a great question here too for Randall. Is there any chance that you are a poet? That our commenter said there is a famous poet with your name.
Well, I am a poet, but it may be the other Randall you're talking about. But yes, I have, yes, several anthologies, a book, and so forth. Yes.
Oh, well, so you're famous in a multitude of ways then too.
Just kind of participate.
There's another comment here. Some caregivers get a lot from the brief training they receive at the hospital. Others walk away wondering who and how to actually perform the injections, catheter changes, because they watch and don't actually experience the treatment tasks. I think, yeah, that's a great, another key piece that we need to be really focusing our engagement on then with others, with caregivers, so that we're not just showing them, we're having them actually do with us too. Really good. I'm gonna see if there's any other.
Absolutely, and that's a focus, with all of our projects. We talk, when we're in the process of developing these, that we're working with them and thinking about how can we apply this to the operations in a healthcare setting, and making sure that with the work that in developing this work, we're not only considering the patient, but the caregiver as well. So that was one of the huge things with that heart failure checklist, and being able to provide a document that can help provide comfort for both the patient who's going through a lot, and then also the family member who's going through a lot as well, and making sure that they can care properly for their loved ones.
Absolutely.
I don't know, Randall, if you want to add anything to that.
Well, I just think it's so important, especially in this current climate that we're in. It's really hard to deal with. And I know, like I said, my mother received hospice care last year, and I had to ask some questions because certain things weren't being done, and we had to first let them know that the hospice caregiver, we're here just to gain the information. We're not here to fight against you. We're here to try to work with you. And I learned, as Kim was saying, how to actually work the catheter and so forth, and how to adjust that and take it out and so forth. And so we had to do a lot of things that we weren't ready for, even giving injections, but we had to do that. So even all hospice care is different. Each person will care, but we really had to do some things that we weren't really prepared for. But just by being a part of this advisory group helped me at least ask questions that put us a little more at ease. It was still kind of hard going through the process of actually doing though.
Wonderful. Well, I just want to thank Jenna and Randall for sharing with us. This gives those of us that are also members of PFACS, whether they're larger ones or from one organization, wow, what a great look into some things that we truly could do. Then sometimes it feels overwhelming, and like you said, there are so many things we could be working on, and it is hard to just choose one to start with. But man, you've given them some great practical, actionable information we can take, and we can do this. So I thank you. We are going to next
and
session.
Also, I just want to add to
yes.
our contact information is on this last slide. So if you do have any other questions, please don't hesitate to reach out to myself or Randall. I'm happy to answer any of those or provide any responses that we didn't get to.
Wonderful. And we are keeping we are making sure we're going to keep all of the comments and questions that were in here too. And again, you will be receiving, I think, a link to all of the slides. You'll be able to go back and see them. And we'll, again, have Jenna and Randall's contact information too. So please don't hesitate to reach out to them. Our next session starts in 4 minutes. And this is, normally at a conference like this, when we're in person, we end at the end of the day and we have a little meet and greet, and maybe we get a glass of wine and something to nibble on. Well, it's not going to be that kind of happy hour here. It's not 5 o'clock where I am, but so we do want you, though, to join us for what we're calling Not Your Normal Virtual Happy Hour, a 10-year celebration of the PFCCC annual conference. So the link is in here too, or you probably have it in other areas, but please join us in just a few moments as we continue the discussion. Thank you so much, everyone.
Thank you, everyone. Have a great day.
Thank you. Enjoy your day.